Hi all, today I am here to take my pharmacology seminar from the chapter alcohol and my topic is clinical uses of ethanol. So, medicinal uses of ethanol are primarily restricted to external application and as a vehicle for liquid preparation used internally. The first use is it is used as an antiseptic. It is an effective antiseptic and cleansing agent at 40 to 90% concentration. The rapidity of action increases with concentration up to 70% and decreases above 90%. This acts by precipitating bacterial proteins. A cotton swab soaked in a 70% ethanol rubbed on the skin kills 90% bacteria in 2 minutes. This has been used before hypodynamic injection and on minor cuts. It cannot be applied to mucous membrane or to delicate skin or ulcers as it can cause irritation and on open wounds it produces burning sensation, injures the surface and forms a coagulation under which bacteria could grow. It is a poor disinfectant for instruments as it do not kill spores and promote rushing. It is used as rubefaction and counter irritant. It is used for sprains, joint pains. Spirit is used as a vehicle for other ingredients. Rubbed into the skin to prevent bud spores. This works by hardening the skin due to its astringent property. However, alcohol should not be applied on already formed sores. The astringent action of alcohol is also utilized in antiperspirant and aftershave lotions. Alcoholic sponges to reduce body temperature. Then, interactable neuralgia, severe cancer pain. Injection of alcohol round the nerves causes permanent loss of transmission. Then it is used as to ward off cold. Alcohol is in the form of brandy may benefit by causing vasodilation of blanched mucosae. But further exposure after taking alcohol may be deleterious because alcohol increases heat loss due to its cutaneous vasodilation. As appetite stimulant and carminative, 30 to 50 ml of 7 to 10% alcohol may be taken as beverage or as tinctures before meal. To treat methanol poisoning, ethanol suppresses methanol oxidation to form aldehyde by acting as a commutative substrate for alcohol dehydrogenase. Saturation of enzyme with ethanol suppresses formate production. Ethanol is administered through nasogastric tube with loading dose of 0.7 ml per kg followed by 0.15 ml per kg per hour. Formiprazole, an alcohol dehydrogenase inhibitor, is approved for the treatment of methanol poisoning. Then aldehyde dehydrogenase inhibitor, and here I have the drug disulfiram. It inhibits the enzyme aldehyde dehydrogenase probably after conversion into active metabolites. When alcohol is ingested after taking disulfiram, the concentration of acetaldehyde in tissues and blood rises and a number of highly distressing symptoms are produced promptly. Disulfiram is used for alcohol withdrawal treatment. It makes the patient sensitive to alcohol. If the patient consumes alcohol, even in small quantities, it leads to a very unpleasant reaction termed as disulfiram alcohol reaction or aldehyde syndrome. And the symptoms include flushing, burning sensation, throbbing, headache, perspiration, uneasiness, tightness in chest, dizziness, vomiting, visual disturbance, mental confusion, postural fainting, and circulatory collapse. The duration of symptom is 1 to 4 hours, depends on the amount of alcohol consumed. Because of the risk of severe reaction, disulfiram is to be used with great caution only in well-motivated subjects. Disulfiram aversion therapy is indicated in abstinent subjects who sincerely desire to leave the habit. After making sure that the subject has not taken alcohol in the past 12 hours, disulfiram is given at a dose of 500 mg per day for 1 week followed by 250 mg daily. Sensitization to alcohol develops after 2 to 3 hours of first dose, reaches its peak at 12 hours and lasts for 7 to 14 days. After stopping it because inhibition of aldehyde dehydrogenase with disulfiram is irreversible, synthesis of fresh enzyme is required for the return of activity. The subject resolve not to drink is reinforced by distressing symptoms that appear if he drinks a little bit. The subject should be given to patients who are physically dependent on alcohol. Disulfiram is used in chronic who have resolved to abstain from consuming alcohol. The drug does not produce beneficial effects in individuals who are physically dependent on alcohol. The drug is also liable to produce toxic reactions which can be fatal, hence these reactions limit its use. The drug is administered only when the patient has been taken into full confidence and properly warned against the serious reactions that would occur if he consumes alcohol. The mechanism of action. This acts by inhibiting the enzyme aldehyde dehydrogenase, which is responsible for the metabolism of alcohol. Ethanol, in the presence of aldehyde dehydrogenase, gets converted into acetaldehyde, in which the disulfiram drug come and act in the presence of aldehyde dehydrogenase, and it forms acetate, which converts into carbon dioxide and water. If disulfiram is taken after ingestion of alcohol, then the metabolism of alcohol is inhibited due to the inhibition of enzyme aldehyde dehydrogenase. The concept of acetaldehyde in blood and tissues rises producing digesting system, which are referred to as aldehyde syndrome or disulfiram aldehyde reaction. Recent studies have also shown that disulfiram inhibits the enzyme dopamine beta hydroxylase, which catalyzes the metabolism of dopamine. Such an inhibition results in increased dopamine level, which further contributes to the distressing symptoms like anxiety, high BP, and restlessness are produced by the drug. Disulfiram and alcohol reaction. This reaction is characterized by flushing, burning sensation, throbbing, headache, sweating, thirst, palpitation, perspiration, uneasiness, vomiting and tightness in chest, visual disturbance, hyperventilation and mental confusion. In severe cases, there occurs depression of respiratory function, cardiovascular collapse, cardiac arrhythmia, MI, acute CHF, unconsciousness, convulsions and death. Disulfiram alcoholic reaction occurs when the concentration of acetaldehyde in blood is 5 to 10 times higher than in normal alcoholics. The enzyme aldehyde dehydrogenase is irreversibly inhibited by disulfiram. Fresh synthesis of enzyme is required for the metabolism of alcohol to return to normal. The undesirable effects of disulfiram alcohol reaction helps in the treatment of alcohol dependence. The duration of these effects may vary from 30 minutes to several hours in severe cases until the alcohol is present in blood. The pharmacokinetics. Disulfiram undergo rapid but incomplete absorption from the GI tract, is highly lipid soluble, hence get easily distributed in the body fat. It is rapidly metabolized into an active metabolite, diethyl thiocarbaminic acid methyl ester, which is responsible for aldehyde dehydrogenase inhibition. Maximum enzyme inhibition occurs after 4 hours of consumption. The metabolites are excreted in urine and disulfiram exerts its action even up to 2 weeks after an initial dose. Then the adverse effects. Peripheral neuritis, polyneuritis, peripheral neuropathy, hepatitis and skin eruptions. Few patients suffer from transient mild drowsiness, fatigue, impotence, headache, acne eruption and allergic dermatitis. Psychotic reaction with high dose of disulfiram and due to withdrawal of alcohol. These side effects disappear upon continuation of therapy or if the dose is reduced. Psychotic reaction with high dose of disulfiram and due to withdrawal of alcohol. Then the drug interactions. Disulfiram when given with metronidazole, perphenazine or isoniazid causes CNS toxicity. Administration of disulfiram with phenytoin causes phenytoin toxicity. Patients on anticoagulant therapy require dosage adjustment as disulfiram prolongs prothrombin time. When co-administered with dopamine agonist, it causes an increase in dopamine levels resulting in insomnia and stimulant psychosis. Diazepam with disulfiram results in increased CNS depressant effects. Disulfiram retards the metabolism of theophylline and tricyclic antidepressants, thereby enhancing toxicity. Then the contraindications. Disulfiram is contraindicated with individuals on metronidazole therapy, MI, coronary diseases, psychosis and DM, individuals exhibiting sensitivity to disulfiram, alcoholic intoxication, alcoholics who have consumed alcohol just 12 hours before, etc. Then the uses are: disulfiram helps in the treatment of alcohol dependence in chronic alcoholics. However, the drug does not assure that alcoholics will continuously abstain from alcohol. Side effects of disulfiram are infrequent rashes, metallic taste, nervousness, malaise, and abdominal upset. It inhibits a number of other enzymes including alcohol dehydrogenase, dopamine beta hydroxylase, and several cytochrome P450 and isoenzyme. Thus, it prolonged T-half of many drugs. So, this comes to an end. Thank you.
Welcome all. I am Shefin. Today we are discussing on methyl alcohol. Methanol or methyl alcohol or wood alcohol was once produced by distillation and fractionation of wood. Its odor and taste were effective for some time in preventing its consumption by humans. However, once methanol could be deodorized, cases of human poisoning greatly increased in number. Methanol is currently used as an industrial solvent for the production of other chemicals, as an ingredient of antifreeze, and as a paint remover. It is also considered as a potential fuel. Methanol is a colorless liquid, easily miscible with water and also on other solvent. It is also added to industrial rectified spirit to render it unfit for drinking. Mixing of methylated spirit with alcoholic beverages by bottliggers or its inadvertent ingestion results in methanol poisoning. Metabolism of methyl alcohol. Methanol is metabolized to formaldehyde and formic acid by alcohol and aldehyde dehydrogenase respectively, but the rate is 1/7 that of ethanol and follows zero order kinetics, and T-half of about 20 to 60 hours has been measured. Methanol is also a CNS depressant but less inebriating than ethanol. Toxic effect of methanol are largely due to formic acid. Since its further metabolism is slow and folate dependent, a blood level of greater than 50 mg per deciliter methanol is associated with a severe poisoning. Even 15 ml of methanol has caused blindness and 30 ml has caused death. Fatal dose is regarded as to be 75 to 100 ml. Manifestation of methanol poisoning appears after a delay of few hours when its toxic metabolites accumulate. These are vomiting, headache, epigastric pain, uneasiness, drunkenness, disorientation, tachypnea, dyspnea, bradycardia, and hypotension. And also delirium and seizure may occur and the patient may suddenly pass into coma. Acidosis is prominent and entirely due to the production of formic acid. This specific toxicity of formic acid is retinal damage, blurring of vision, congestion of optic disc, followed by blindness always precedes death, which is due to respiratory failure. Treatment: keep the patient in a quiet dark room, protect the eyes from light. Gastric lavage with sodium bicarbonate if patient is brought within 2 hours of ingesting methanol. And also supportive measures to maintain ventilation and BP should be instituted. And here is an image of gastric lavage. Combat acidosis by IV sodium bicarbonate infusion. This is most important measure which prevent retinal damage and other symptoms. Large quantities may be needed, which neutralize the sodium bicarbonate infusion, which can neutralize the acidic conditions. Next, potassium chloride infusion is needed only when hypokalemia occurs due to alkali therapy. Ethanol. Ethanol is preferentially metabolized by alcohol dehydrogenase over methanol at a concentration of 10 mg per deciliter in blood. It accelerates alcohol dehydrogenase and retards methanol metabolism. This helps by reducing the rate of generation of formaldehyde and formic acid. Ethanol is administered through a nasogastric tube loading dose of 0.7 ml per kg followed by 0.15 ml per kg per hour. Because of the pharmacokinetics of alcohol changes over time and no IV formulation is available, Maintenance of uniform blood alcohol concentration is difficult. Alcohol blood level needs to be repeatedly measured. Moreover, the enzyme saturating concentration of ethanol itself produces intoxication and can cause hypoglycemia. Use of ethanol for this purpose is tricky. Treatment has to be continued for several days because of temporary stay of methanol in the body is long. Hemodialysis. Hemodialysis clears methanol as well as its toxic metabolite format and hastens recovery. The drug formimizole is a specific inhibitor of alcohol dehydrogenase and the drug of choice for methanol poisoning, which acts by retarding its metabolism. A loading dose of 15 mg per kg infused IV over 30 minutes is followed by 10 mg per kg every 12 hours till serum methanol falls below 20 mg deciliter. This has been found effective and safe and has several advantages over ethanol. Its longer T-half, lack of inebriating action and IV dosage form for regulating administration. Marketed as Andisol, not available commercially in India. Adverse effect: burning pain in infused limb, headache, nausea, taste disturbance and hypotension. Next one, folate therapy. The drug calcium leucovorin 50 mg injected 6 hourly has been known to reduce blood formate levels by enhancing its oxidation. This is a promising adjuvant approach. Next one, ethylene glycol poisoning, which is similar to methanol poisoning. It can cause intoxication similar to methanol. Formimizole, used in the same manner as for methanol poisoning, is the drug of choice. That's the end of the presentation. Hope the topic is clear to you. Thank you.